Jack Arnold. I'm a clinical lecturer at the University of Leeds, and I'm presenting a case from Leeds, which is a case of initially a lupus nephritis case, which via a few twists and turns progressed to a lupus myocarditis case, and hopefully is less tragic than that pun I've put in the title, so fingers crossed. No relevant conflicts of interest. So here's our case. So she's a 43-year-old self-employed office cleaner. She's previously very fit and well up until the events that led her to come into hospital, very keen hiker, and just very physically active generally. And she presented to hospital on the 12th of March this year with proteinuria, pancytopenia, and a crushing AKI. And she also described, among other things, some diarrhea, some dysphagia, but very notably, very severe nausea, which was refractory to most normal treatments and actually ended up requiring a syringe driver. So she was admitted to hospital under the care of the renal team, but on further questioning, it became evident that she'd actually had 5 to 6 months of constitutional symptoms with quite severe weight loss, night sweats and fevers, which her GP had been looking into in the community. And they'd actually gone on to arrange a bone marrow aspirate in February of the same year because of concern regarding this, which hadn't shown any dysplastic features. But when she came in, she was anemic. She had an HP of 71. She had a platelet count of 59, and she had a white cell count of 2.4 with very low lymphocytes. And her urea was 19, creatinine was grossly elevated at 348, albumin 23, and she had a potassium of 5.4. Urine dipstick when she came in showed nephrotic range proteinuria with evidence of hematuria. And she went on to have some immunological testing, which showed positive ANA with a positive double-stranded DNA, row 60, SM, and SM-RMP antibodies. So lupus in full flow. Because of the previous weight loss and fever, she went on to have a CT chest, abdomen, pelvis, which showed, among other things, a right-sided pleural effusion, evidence of mild splenomegaly, and notably bilateral axillary, subpectoral, and cervical lymphadenopathy. So she had a very, very complex history with multiple admissions, self-discharges coming in and out. So I've tried to summarize it as best I can here and leave out the extraneous details. But on this initial presentation with proteinuria and splenomegaly, she went on to have a renal biopsy, which confirmed class 3 nephritis. Electron microscopy showed no evidence of associated class 5. And this was done at a peripheral hospital in, so she was admitted initially to a peripheral hospital and then transferred to Leeds subsequently, where she had the biopsy. And following this biopsy was started on prednisolone at high dose, mycophenolate and hydroxychloroquine. Because of the severity of her disease, she went on to have 2 cycles of cyclophosphamide and was treated with rituximab. And unfortunately, later that in April, her third cycle of cyclophosphamide was delayed because of severe neutropenia, which also necessitated holding her mycophenolate. And she had quite a long admission and eventually ended up with a 3rd cycle of cyclophosphamide on the 13th of the 5th. We rechecked her B cells earlier in that month as well after the first 2 cycles of rituximab and found that she still had detectable B cells. So she was actually given a 3rd cycle of a 3rd dose of rituximab on the 7th of the 5th. But she had a very long admission on a medical ward. She was struggling with the noise. She was in a 4-bedded bay. It was very noisy. She was struggling with it. And actually, she self-discharged herself before we could continue her workup. But unfortunately, she didn't stay home for very long because she came in twice subsequently in May and June, initially with febrile neutropenia, quite impressive neutropenia. Neutrophils were about 0.2 at the time. She had diarrhea and abdominal pain at the time and actually had another CT scan to look for evidence of typhlitis, which was negative. So she stayed in for the CT scan, was given some empirical antibiotics, but then self-discharged. And she managed about another week at home before coming back in again with LFT, with a massive LFT rise, which she also self-discharged prior to any workup other than an ultrasound, which excluded a thrombus. But she, again, self-discharged. But on the second time, when we did her follow-up bloods, her LFTs did normalize without treatment. So she might have had a point at that time, but the first time, perhaps not. So this all went on, and then she came back in August with very severe anemia. So her hemoglobin had dropped down to 58. She was edematous, she was dyspneic. She had a CT scan when she came back in because there was some concern about a possible atypical infection given the degree of immunosuppression that she'd had. And at that point, she had a troponin check for the first time, a troponin I check, which was 138. So she'd been treated for this refractory edema for a prolonged period of time, but it was only really at that point that we checked any cardiac markers. And because of that, she went on to have further investigation for possible myocarditic involvement from her lupus. She was transfused, diuresed, and then arranged for an echocardiogram. So this is her echo. I'm not a cardiologist, but I'm going to have a crack at it. So with some notes. So her echocardiogram showed left-sided dilatation in the ventricle and the aorta, and the atrium rather. Sorry. It showed generally severely impaired LV systolic function, which I think you can see on the right of this slide. And then I'll get a few more images up. The four-chamber view shows, to me, shows some global reduction in contractility, and there's evidence of mild mitral regurgitation in the right image here. So on the basis of this and the troponin, she went on to have a cardiac MRI, which is shown here. And the cardiac MRI demonstrated globally reduced systolic function with a left ventricular ejection fraction of 46% and a right ventricular ejection fraction of 47%. Both ventricles were noted to be dilated. There was no scar or thrombus. And no established fibrosis or infarction with no late gadolinium enhancement. Pericardium was normal, but there was evidence of bilateral pleural effusions and evidence of quite reasonably good going left ventricular systolic dysfunction. Late gadolinium images showed no evidence of fibrosis or scarring, so everything to play for here. With regards to her ongoing management. I feel somewhat under pressure after that lecture on T1 and T2 mapping, but her cardiac imaging showed prolonged T1 and T2 phase consistent with generalized myocardial edema and inflammation. So in summary, we've got a patient who presented initially with lupus nephritis, but subsequently has developed lupus myocarditis, or may have had some aspect of that really right at the initial presentation. But this has been refractory to prednisolone, mycophenolate, cyclophosphamide, which he's had 3 cycles of at this point, but has been hampered by persistent neutropenia and 3 doses of rituximab. She was admitted into the hospital and went through the rheumatology MDT, and there was ongoing concern about whether she had an atypical fungal infection based on some findings from the CT scan. And there was discussion about whether she would need a bronchoscopy prior to any further treatment. She did, however, improve with conventional antibiotics and with diuresis, so we didn't pursue the atypical infection route any further at that point. But that was the reason why she was treated with 7 cycles of plasma exchange and subsequently given IV belimumab. And after her counts normalized, she was restarted on mycophenolate. And her current status is, so this is slightly out of date because she went home a couple of days ago, but she was still on diuresis under management with the heart failure team and on a furosemide infusion. I can give a sort of hot off the press update because I got an email about her this morning. But she's come back in profusely hyperkalemic and we're trying to bring her back in, but she's been reluctant to come into hospital at this point. So we're trying to manage her as optimally as we can do, but she's very reluctant to stay in. So it's been challenging to say the least. So more a talk for the sort of juniors rather than the consultants in the room. I've quoted a prevalence of about 5% for lupus myocarditis, but this does vary a lot between cohorts, and I think it's actually 6% in this 750 patient cohort. The presentation is very non-specific, chest pain, dyspnea, and palpitations, and in up to 40%, there'll be evidence of overt heart failure. Interestingly, in these patients, myocarditis is the initial index presentation of lupus in about between 30 to 70%, which I know is a very wide range. But I found quite interesting that there's concomitant lupus nephritis in between 40 to 70% of cases. So I don't know whether there's a complement-mediated pathology there that's linking those two. In terms of common lab findings, lymphopenia and thrombocytopenia are very common in these patients. Positive anti-double-stranded DNA and anti-RMP, which won't surprise many people, and low complement, so low C3 and C4 levels, in keeping with what I mentioned earlier. I just wanted to highlight this study which came out this year in rheumatology. So this was a multi-center cohort study which compared 25 patients with myocarditis secondary to lupus with a cohort of 279 pure lupus cases and 88 pure myocarditis patients. And they gleaned a few things from that. So they found that women predominated in lupus myocarditis, 72% of the cohort compared to only 43% of the pure myocarditis cohort. They found a greater incidence of conduction abnormalities in the lupus myocarditis groups and greater LV dysfunction and pro-BNP levels in the myocarditis secondary to lupus rather than pure myocarditis. And then looking at the bloods, they found higher inflammatory markers in compared to the pure myocarditis groups and higher rates of antiphospholipid associated antibodies. And finally, in comparison with those with just pure lupus, those who had lupus myocarditis have far higher SLE-2K values. I couldn't comment on the biolab, but the SLE-2K was grossly elevated. And just in terms of management and outcomes, there's no clear guidelines on this. I mean, heart failure therapy, as we discussed earlier, if relevant, and then generalized immunosuppression initially, usually with high doses of IV or oral steroids, and then either cyclophosphamide, rituximab, intravenous immunoglobulin or plasma exchange, all used really on case study evidence rather than anything else, and then oral DMARDs, most commonly mycophenolate. Outcomes in a 14-year French cohort study with follow-up of about 37 months, they quoted a global mortality of about 10%. I mentioned that there's not really any clear guidelines on this. This is probably as close as I could get to this. So this is a recent sort of expert consensus cohort study from the combination of the ERM, RECONNET, SLIC, and SLE Euro expert groups. And they mention a few severity criteria which guide treatment. So either the presence of cardiac failure or reduced ventricular filling volume, kinetic alteration on echocardiogram, arrhythmias or conduction abnormalities, or diffuse myocardial edema. If those are present, they favor a high-dose prednisolone taper, but also the inclusion of urolupus regimen cyclophosphamide, which is less than we would use locally in the department. We gave her NIH protocol cyclo. And then they suggest that if these aren't present, then just prednisolone taper with mycophenolate. So learning points, I think for us, it's to maintain a high index of suspicion for lupus myocarditis because it doesn't always declare itself. And in the context of other things like lupus nephritis or globally active SLE, I think it can be lost in the shuffle somewhat. To consider cardiac biomarkers and echocardiogram and scans early, and to increase cross-specialty collaboration between cardiologists and rheumatologists to try and improve outcomes. Those are my references, and happy to take any questions. Thanks.
Actually, maybe I'll start with a comment in the chat because it's quite interesting. Was ferritin checked, and because this raised the possibility of HLH. Some of our colleagues and Rachel Tattersall, Sheffield, she quotes this: 50% of acute presentations of lupus have HLH. Did you consider that?
It was checked initially, yeah. The index, I think it was elevated, but not in the HLH range. But it was considered early on when she failed to respond to.
So more as a general inflammatory marker, rather.
Yes, yeah. It was considered. I think she had an H score early on in her treatment as well. But I did.
So any questions here? Because I think we've got a couple online. Yeah. Any questions here? No. How can we bring the colleagues online?
Yeah, Dr. Das, go ahead.
Hello, hi, Shovik Das from Leeds. So I know this patient well from the rheumatology team. Nice to see you, Sven. Great to see Maya and Taryn. This is a really great meeting. Thank you. And thanks to Jack for a good presentation there, and Havika for earlier on as well. Just on the ferritin point, Rachel, absolutely. We did check in. It was before, I think, Jack was back to Leeds, and there was a period where the ferritin was up. It was about 2,000 to 3,000. We did give her some anakinra for a period of time because I thought at that point this neutropenia is not drug related and perhaps disease related, and perhaps certainly HLH in the context of SLE. The question I had a specific point and then a general point really to put to colleagues in the room and experts. The challenge with this difficult patient, I think, is difficult in terms of disease severity, has been to, in the next few weeks and months, to decide whether she's responding or not. And her renal function did improve to an eGFR of about 30 or 40, but then has now dropped back again. And she's in a really parlous position there. I wouldn't be surprised if we end up doing another renal biopsy. But from a cardiac point of view, again, I suppose my question is really when and how should we monitor that disease with further MR, with echo, with the role of the cardiac markers? How frequently, how soon should we expect it to change? And I think at the moment we're partly in a bit of a loop of cardiac and renal disease and drug therapy complicating each other. So cardiac status and cardiac medication is pushing renal disorder. The renal status is making the cardiac management more difficult. And my more general point is that I think part of the difficulty in helping her has been, I think she has, and our consensus is that she probably has a degree, as many of these patients do, a degree of neuropsychiatric lupus, which is making adherence to medications, her sort of how she's feeling in herself difficult to manage. And I wonder if that's where face-to-face consultations with joined up clinics, she's in a joint rheumatology and renal clinic with myself and my colleague, but we have great MDT links with cardiology. I just wonder if sometimes seeing these patients face-to-face together to really talk through things brings it home to patients and their families. And that applies actually also to the case that Bhavika presented as well. I think in a patient with such severe cardiac disease, it's unusual for me to see that level of cardiac disease. Therefore, it's difficult for me to assess the rest of her symptomatology. Lupus patients can be so polysymptomatic. And equally, when a cardiologist sees a patient like that and is very symptomatic, I think maybe being in the same room together might help as well. So grateful for any comments or advice.
Yeah, maybe I can just try and give a response to how often she should be imaged. I don't think she needs an MRI scan regularly because we know she's got myocarditis, or everything looks like she's got myocarditis from her underlying systemic illness. And if you rescanned her, I don't think it would have necessarily therapeutic consequences beyond ejection fraction at this point. I do think she needs regular echo. You want to know whether the ejection fraction goes down. She's already 47%. She's in a bit of trouble here. So I would echo her very regularly. And any further deterioration of her systolic function, dilatation of the left ventricle should, really let alarm bells ring. The challenges then of treatment with the renal disease, or maybe more generally, what it felt to me as the presentation went on that this patient should be on a ward, being managed aggressively under supervision, and then with joint care from cardiology, renal, rheumatology, but doesn't sound like she is willing, to have that. But definitely, I think for these patients, having a cardiologist come round, as we do for many other inpatients at St. James's. So unfortunately, for those who are not from Leeds, the rheumatology hospital is a little bit away from the cardiology hospital. But definitely getting a cardiologist around to look at it every now and then would be definitely helpful.
Okay. Thank you, Sven.
Dr. Badal, I think online has a question.
Actually, sorry, Dr. Das has already pointed that out. I was thinking that obviously most sensible people would want to run away from NHS chaotic wards. So not surprised that she wants to leave. But she might well have a neuropsychiatric problem that is preventing her from having regular medical assessment and treatment.
it's interesting with her case actually, because she's quite a keen artist, and she, throughout the course of the admission, started to struggle with the ability to actually construct as she was before. So she had she presents as very as appearing to take everything in, but whether there's some higher executive function that's just being impaired that is at a level that we're not picking up from the day-to-day in the conversation initially. But yeah, it's quite interesting.
Yeah, well, obviously this is a very complicated case, and given the lack of response or partial response to the multiple treatments she has had, I was wondering about CAR T-cell therapy for this patient. I don't think she would fulfill eligibility criteria for the current trials because she's not well enough. And also there are the contextual issues. But if you manage to improve things enough, maybe that's the only possibility, because I think it's very unlikely that these drugs or combination of drugs is going to actually lower disease activity enough. So I was thinking about CAR T-cell therapy, but obviously in order for that to happen, a lot of things would have to improve. Yes,
compliance has to be
it's
fantastic.
a very difficult scenario.
Karen.
Hi, yeah, thank you for a lovely presentation, very interesting case. So just to answer Shovik's question, I think as well as the echo, we need to track cardiac biomarkers. You're lucky, you've got troponin here, you can keep checking it, and that will help you to understand whether she is responding or not to treatment, and we frequently do that. I also find that cyclophosphamide is a great tool to increase patients' engagement. So Andrew and I find that we can see a patient every 2 weeks when they're coming in for IV cyclo. It really helps. You can see them just pop in for a few minutes, just check how they are. These guys do that, and I think it's important to recognize that patients often respond to our increased engagement with them, and so that does actually help, I think, overall management. I just really wanted to also say about echo that it's very important, and I know cardiologists will understand this, but rheumatologists don't really understand when you request echo, or often don't understand, and I didn't used to, so forgive me if I was just more stupid than the rest of you, but you can't just request any old echo. These echoes need to you need to be very specific about what you're asking for, and I think you need departmental echo, and you need to be able to assess diastolic dysfunction, because otherwise you're going to miss some of the lupus myocarditis, I think. But maybe I'm wrong. Sven can come in after. But really I wanted to emphasize for the whole audience how serious lupus myocarditis is, and I think when you've seen it once or twice and you've seen a patient very, very suddenly deteriorate and die on the ward, it is often from this condition. This is what causes young women to die in rheumatology. We've all seen it here. I've had several patients, unfortunately, but many more that we've got better. These patients often are, as Shovik described, they have a neuropsychiatric element to it. They want to go home. They don't want to stay in. There's a lot of pressure to get patients out of hospital. These patients need to be in hospital. They need to be on a cardiac monitor, and they need to be treated really aggressively at the initiation of therapy, because otherwise they do very poorly. Thank you.
Yeah, I think that's a really good summary. Certainly reflects what I was thinking as well. I think the echo in asymptomatic patients, the diastolic function important. This patient already has heart failure, so I think you just we would in other circumstances, in other patients, we would keep an eye on these with straightforward echo just to see that the ventricle hasn't suddenly gone boom, because then prognosis really begins to be dreadful.